everyone. A very warm welcome to all our esteemed panelists and everyone joining us here today for this important discussion on yes, we can end TB from commitment to cure. I'm Dr. Muskan Alawat from Team Voice of Healthcare and I will be leading today's session. Tuberculosis continues to be one of India's most pressing public health challenges. Despite decades of efforts, India still contributes nearly a quarter of the global TB burden, which tells us that while progress has been made, significant gap remains. But today, TB is not just a disease burden, it is a reflection of gaps in early detection, access to care, system integration, and awareness. At the same time, we are also at a very promising juncture with advances in molecular diagnosis, newer treatment regimes, and stronger policy commitments. We are now having the tools that are required to accelerate TB elimination. The real question that arises here is that are we effectively connecting these advancements across the healthcare systems from early detection to timely diagnosis to effective treatment pathways? So today's discussion is all about aligning these elements into a cohesive strategy because ending TB will not require just medical progress but coordinated action as well. With that, introduce our esteemed panel for the day, and we are privileged to have Dr. Satyanarayana Mysore, Chairman, Core Clinical Council Chairman, and HOD and Consultant from Clinical and Interventional Pulmonology and Sleep Medicine from Manipal Hospital, Bengaluru, and Adjunct Visiting Professor at MAHE. Welcome, sir.
Thank you.
Next, we have Dr. Anup R. Warrior, Senior Consultant, Infectious Disease from Aster Medicity, Kochi, and Group Chief of Medical Affairs and Quality at Aster DM Healthcare India. Welcome, Dr. Anup.
Thank you. Thank you.
We have Dr. Prashant Saxena with us, Principal Director and Head of Pulmonology, Critical Care, and Sleep Medicine at Fortis Hospital, Vasant, Kunj, Delhi, and Gurugram branch. Welcome, sir.
Thank you.
And we have Dr. Urvashi B. Singh, Professor and in charge, Tuberculosis Division, Department of Microbiology, AIMS, New Delhi, and former Deputy Director General from National Tuberculosis Elimination Program. Welcome, ma'am.
Thank you.
Thank you to all of you for joining us at this important dialogue. And let us begin with, understanding the current landscape that where do we stand in fighting against TB? So, starting with, we often, speak about TB as a treatable and curable disease. So, I'll begin with Dr. Satyanarayan. Sir, in critical care settings, how often do you encounter late stage or missed TB cases?
Delayed patient presentation or symptoms that have been overlooked or mild symptoms ignored early, or TB still unfortunately carries a stigma in certain sections of the society. Therefore, all these factors prevent timely healthcare seeking behavior. Number one, it is the symptom that will force the individual to take assistance from healthcare. Secondly, there is atypical and smear negative disease, which is increasing cases with minimal radiological findings, not much of X-ray or CT scan initially, or imaging not done, negative sputum in immunocompromised patients. These are some of the factors that will kind of delay presentation to healthcare. This thing. So limited, there may be areas where there is limited access to rapid molecular tests, under recognition, and finally, the symptoms of TB overlaps with many other respiratory diseases. There will be gaps in the drug resistance detection pattern. So all these factors matter in an individual presenting late or not being picked up timely.
Thank you so much, Dr. Satyanarayan, for mentioning those important factors, that persist to delayed diagnosis and often sometimes they missed, TB diagnosis as well. So moving ahead, to Dr. Anup sir. With the rise of drug resistance TB, how is the clinical management of TB evolving? And what are some new treatment approaches that are showing very promising in India?
Right. So, just to lay context, it is said that globally, if you look at the overall incidence of drug resistance or MDR TB, the Indian subcontinent, we are supposed to have about nearly a third of this. So, that's a significant burden, and therefore, we do need a very focused strategy to handle this MDR TB. Coming to the specific question, that means how the MDR TB management has been evolving, or what new treatment approaches are coming up. We know that for a long time we were forced to treat drug resistant TB for nearly 2 years, sometimes even longer. 18 to 24 months was the standard in most of the recommendations and guidelines. Now, with advent of newer drugs, there are multiple regimens which can be used as short as 6 months. That is, we can treat drug resistant TB almost with the same duration as we treat drug sensitive TB, that is 6 months. There are multiple regimens which are studied and recommended by the World Health Organization, and also one, the BPAL, which has been adopted and used even by our national program. So newer drugs like bedaquiline, delamanid, then use of linezolid as an add-on drug, then pretomanid. So there are multiple newer drugs which have come in, specifically bedaquiline, pretomanid, and delamanid based regimens, which have shortened this duration from 18 to 24 months to 6 months. So just to reiterate, I think the biggest development which has come and which has made all the patient's life and our life easier is the shorter regimens with the new drugs.
Thank you so much, Dr. Anup, for the newer treatment approaches that are available in India for TB as of now. So now coming to some diagnostic challenges, Dr. Prashant, what are the biggest challenges you face today in diagnosing and managing TB patients, particularly in detecting early cases as well?
The most important factor which comes is delay from the side of the patient. Now, why there is a delay? Because most of the times the symptoms are non-specific. There is fever, there is non-specific weakness, malaise, or maybe loss of appetite, slow weight loss. So these all symptoms patient tend to ignore, and they will take some over-the-counter medicine for cough or fever, or they will take something else. The reason is that they just sometimes the work schedule is like that. They're not able to come to the hospitals. And number two, even if they are prescribed some tests, even though we may be practicing in metros, but there are many centers where there's a lack of availability of molecular tests, and that is a major factor where they lack a early diagnosis. Then we have inconsistent practices also amongst the doctors. Sometimes, I've seen patients who are on antibiotics for 2 weeks, 3 weeks, 4 weeks because of the fever. But there is no effort to actually look inside what exactly is happening to the patient. So there is a inconsistent clinical practices also. And sometimes the presentation of tuberculosis may be altered due to comorbid illnesses like diabetes, immunosuppression, patients who are malnourished, liver diseases. They can have non-specific symptoms like weakness and malaise, that's it. So that also sometimes is challenging. And coming to the extrapulmonary tuberculosis, that is another factor because most of the patients with extrapulmonary tuberculosis will not come with a clinical cough, fever, weight loss. They sometimes have just weakness or a very low grade fever, and it is difficult to diagnose extrapulmonary tuberculosis. So these are the main challenges which I have seen in my clinical practice in diagnosing these patients.
Thank you so much, Dr. Prashant, for that descriptive answer. Sir, as you were mentioning about patient factors, so I have a question regarding that. Uh, when should a person or a patient, be at a fire dose for TB? Like any symptom or sign that they should notice that I might get TB from this, and they should go to the pulmonologist or the general physician for TB testing.
See, any patient who has an unexplained cough, fever, or weight loss which is lasting for more than 3 weeks definitely needs to be seen, screened, and examined properly and looked at as if he has TB, because we are living in an epidemic of TB. We know 95% of the cases of tuberculosis come from India across the world. So we have to be very careful in any patient who has unexplained symptoms which are lasting too long.
Thank you so much, Dr. Prashant, for the clinical insight. Moving onwards and coming to diagnostic have evolved significantly in recent years. So we would like to know from Dr. Urvashi that how have rapid molecular diagnosis transformed ma'am TB detection in India?
Uh, you see, I'd like to actually briefly add to the previous speakers as well, if you permit, if the speakers don't mind. Under the program, we rolled out the BPAL M for treating the MDR TB, where the treatment, like Dr. Warrior said, is 6 months. It's just four drugs as compared to the earlier, multiple drugs that we use, 6 to 7 drugs we used, and the period is 6 months only. You see, the inclusion criteria and exclusion criteria for BPAL-M do take care of prior exposure or prior treatment with bedaquiline or one of the drugs that are being used, and a few other clinical criteria decide whether the patient can take it or not. But the outcome on the BPAL-M regimen is that the treatment success is close to 90%. Earlier, we were getting close to 75%. The 9 month regimen gives us about 75% success rate, while the BPALM is giving us 90% plus. And now we have, if the patient cannot get BPALM, he'll go on the shorter oral. If he cannot get that, then he'll go on the longer oral, which is 18 months. So much so for the MDR TB treatment. And I'd also briefly add to what Dr. Saxena said, the symptoms. Under the program, while I was a DDG, we expanded the symptoms to also include early, very early symptoms like weight loss, loss of appetite, evening tiredness, or evening rise of fever. Dr. Saxena already alluded to fever, cough, sputum with the blood, that is hemoptysis. We have also included, signs to look for extra pulmonary signs. For example, if there's a lymph node in the neck, if the person has, swelling in any part of the body. So basically, what you were asking earlier, when should a patient approach the system? What Dr. Saxena beautifully alluded to, that the symptoms are very subtle. The patient tends to ignore them. This is the contrast between COVID and TB. The COVID would strike with high fever. TB is also spread through droplets like COVID was being spread, but people do not give as much, they're not so concerned about TB, while it is the biggest killer after COVID. Now COVID is not there, so it gets the first place, biggest killer, and the transmission goes on from one patient to another unless we diagnose every patient early. So coming back to your question to me, how has the diagnostics evolved? Let me tell you, the nucleic acid amplification test came in 2011 with Gene Expert coming in India. We adopted the Gene Expert, but we simultaneously started working on our own Indian indigenous technology, that is TrueNat. So, four centers, we did a multi-centric study with ICMR support, and we were able to validate TrueNat. And today, under the program, we have close to 10,000 NAT systems available to us, of which about 8,000 plus are TrueNat systems and close to 1,800 to 2,000 are Gene Expert systems. And this being an Indian indigenous technology, the production is within the country, doesn't get affected in during war, during pandemics. And we have some newer diagnostics coming up from within the country. The PathoDetect system, again validated by ICMR, has been adopted by the program. Open RT-PCR are new developments that are coming in, bringing the cost down, enabling us to diagnose more cases. What we rolled out in the program was active case finding using handheld x-rays, so that a medical mobile medical unit could mount a TrueNat system and an x-ray system on the mobile medical unit, and these can be taken in camps to the villages where screening can be done for vulnerable risk groups, which are diabetics, HIV, smokers, alcoholics, past TB, those in contact with TB, low BMI population, and geriatric population, who contribute practically to 80% of TB burden in the country. So this was rolled out as active case finding in the TB Mukt Bharat Abhiyan 1, and today our Honorable Minister for Health would be rolling out the TB Mukt Bharat Abhiyan 2. This has contributed in a significant way in diagnosing subclinical or asymptomatic TB, and our notification straight away jumped from 26.7 lakh to 32.65 lakh with the TB Mukt Bharat Abhiyan, of which 11 lakh were asymptomatic cases who would not have come to the health system because they had no symptoms. But since the system could reach to them, we were able to diagnose and treat them early and not let them worsen till a stage when, due to their comorbid condition, their treatment may become difficult, and saved them the trip to a tertiary care hospital, really. So I hope I have been able to answer your query. So a lot of development. India is globally the first to do this active case finding at a large scale, has so many NAT being done. We are doing more than 2 to 3 crore NAT tests. We are scaling up NAT in such a way that for early diagnosis, for baseline diagnosis, we are trying to offer NAT tests to every person who needs it, not only to a presumptive TB, but anybody who has an abnormal shadow in an X ray. Thank you.
Thank you so much, Dr. Rushi, for those clinical insights over tuberculosis and differentiation from COVID as well, and the importance of timely consultation. And as you, ma'am, shared about the in house diagnostic facilities and some statistics about the test for TB population in India. Thank you so much, ma'am. Moving onwards, as you were, talking about identifying the problem, we shift towards understanding what needs to be changed within the system. So, coming to Dr. Satyanarayan, sir, how can referral pathways between primary care and tertiary hospitals can be strengthened?
That is an excellent question. First is normalization of testing for TB in every respiratory care. Screen every patient with cough more than 2 weeks, fever, or any constitutional symptoms, that is, weight loss, hemoptysis, no exceptions. And embedded TB screening checkpoints in OPD, inpatient care templates, so that it becomes a routine and not an optional. It becomes a no brainer that it should be done and we screen for TB. Use a rule out TB first mindset before labeling cases as pneumonia, airway disease, post viral cough, and other things, or even worse, reaching for an antibiotic, unless clinical required need precedes this. The NAT, CBNAT, TrueNAT, all this make rapid diagnostic the default. Of course, the programs have always said that. Currently, stress is more on getting TrueNAT, CBNAT, and gene expert in our center rather than looking at AFB smear, where subjectivity is being replaced by objective and very quick testing. So there is also scope for reflex testing. That is, if the X-ray is abnormal, generate a NAT referral. Then referral pathways, we need to make them simple and trackable. What do I mean by this? Standardized referral protocols between primary, private clinics, TB centers. Nikshay is a wonderful digital tool which will help in notifying, track, and close the loop on every referred patient. So there is no um, loss of follow-up, continuity of care not being interrupted. That does not happen. And assigning responsibility at a center also is very important. Have a person, named person or a team for completion. Integration of TB screening into every respiratory touch point, whether it is pure chest clinic, flu or COVID in the past, diabetes clinics, ICU should all have TB screening trigger points. Routine X-ray plus symptom screen for all high-risk individuals, which is metabolic diseases like COPD, airways disease, elderly, immunocompromised. It may also be a good pathway to screen all hospital admissions for respiratory complaints related to TB. Engage and align with the private sector. Sensitize private practitioners for regarding early TB suspicion and mandatory notification. This has always been up till last 2 years. Lack of compliance with the mandatory notification. I think the governments across the state have always kind of worked under the NTEP to strengthen this particular pathway. Easy access to free diagnostic and treatment under NTEP. The biggest asset will be public-private mix model, which at Manipal we follow with our local TB health authorities, whether it is reporting, whether it is procurement of medicine, testing, of course we do. So ensure rapid reporting of results, same day, next day NAT, communication of the result both to the patient's family, referring clinician. This is also very important. And the training and reminding continuously. Regular CME sessions, the Karnataka Pulmonology Association, example, conducts once in 6 months some sort of a TB program with the under the agencies of NTEP or along with NTEP. So you look at atypical TB presentation, smear negative TB, drug resistance, any unexplained symptom, think of screening for TB. Also, link screening for contact tracing and follow up. So, if I have to kind of put everything in one line, make TB screening automatic at every respiratory encounter and ensure suspected case moves through a fast, reliable, trackable referral pathway with upfront molecular testing.
Thank you so much, Dr. Satyanarayan, for those important points on linking all the referral trackable pathways, whether from screening to training of professionals as well. And I think a seamless referral system can truly make a difference between some early intervention and delayed care as well. Sir, you were mentioning about a digital tool for screening, I think. So, could you explain a bit more about that?
So, this is known to everyone. There is the Nikshay app. So every positive case, every tested sample gets upon referral gets registered on Nikshay, and ID is created, and that creates a pathway for the team to follow up. So this is done even at the level of PHCs, probably done much better at the PHC level. So even though Manipal is a private hospital, any test, whether it is a NAT test or a true NAT or a gene expert that has come positive, it is conveyed to the PHC level. A Nikshay ID is created, reported, and the strengthening of the reporting is going to be one of the hallmarks of the success of the program. So the app is actually the Government of India app under the NTEP.
Thank you so much, Dr. Satyanarayan, for sharing those insights with us. Moving onwards in our conversation, coming to Dr. Anup, sir, what role do shorter treatment regimes and new tuberculosis drugs play in improving patient adherence and outcomes, sir?
Yeah, so just I would like to add, like what Dr. Urvashi was mentioning, something regarding the clinical signs and symptoms also. What I wanted to highlight was that I come from a private sector, and as Dr. Satyanarayana mentioned, we work in quaternary care private setup. So in my practice and in my hospital, not just practice, because we also report regular NICSHI, so we get an analysis of that. 5 out of 10 TB diagnosed are extrapulmonary for us. Okay. Really 50% are extrapulmonary. So all these symptoms, majority of the symptoms, we focus on pulmonary, chest, respiratory symptoms, etc. But we in private sector, something like that, we see a major chunk of extrapulmonary. If out of 10, if 5 are extrapulmonary, 1 or 2 are disseminated. That means they have nose and abdomen, or they have CNS and lung. So multiple areas being involved. and only three or two or three are just pure pulmonary TB, like what classical with the respiratory symptoms and all. So diagnosis of extrapulmonary tuberculosis, still there are a lot of hurdles compared to the pulmonary tuberculosis, especially CNS TB and sometimes abdominal TB, etc. So one thing which I wanted to add is that any chronic ulcers, any long duration or subacute mass lesions, okay, unless the biopsy etc says always send for this CBNAT or TrueNAT etc, AFB screening, TB culture. What we had done is we had bundled this TrueNAT or CBNAT along with AFB and TB culture uniformly, so that the clinician or the surgeon, whenever he sends a tissue or a lymph node or a mass from the abdomen etc, all three are done together. So we diagnose more because culture get done default, CBNAT get done default on all this. So this is for extrapulmonary, this is very important, because what happens is otherwise the biopsy report comes as chronic granulomatous disease and then they are referred. And by the time that window of diagnosing TB, doing susceptibility test, etc. is gone. So that said and done, I'll come back to the question that what has short duration drugs added to the treatment of MDR. So we had two major challenges with treatment of MDR TB because of the long duration. One was the adherence, because expecting somebody to take for 1.5, 2 years, 1 year to 2 years on a regular basis, even when symptoms are better, was a problem. Cost when it is in private, but obviously from the government they will be supported. Along with the adherence problem was also the issue of toxicity, right? Because all these drugs have their own kind of toxicity, and to manage this toxicity over such a long time, especially when it was injectable, was a problem. Now this, with this short duration, what we have achieved is that from the clinical perspective or from the physician perspective, we are much more comfortable because we don't have to handle that much of toxicity over long term, and hence the patient tolerance is better. And because of this patient tolerance and the short duration, the adherence is better. And because of all these things put together and the drug effectiveness, we have excellent success rates, as Dr. Urvashi was mentioning, of 90% or more. So just to reiterate, it has improved adherence, it has made managing toxicity, it has made toxicity lesser, and hence managing the drug tolerance and the patient profile on ATT much easier for us physicians.
Thank you so much, Dr. Anup, for mentioning those two critical points about adherence and toxicity for the newer, shorter treatment regimes that we are following. And I think you correctly mentioned that diagnosis has always been a major challenge in TB. And so this was a very important highlight that you shared. So moving onwards, coming to Dr. Urvashi, ma'am, what innovations in diagnostics could help better detect TB faster, especially in resource limited settings?
I actually beg to differ when you call a resource limited setting if you're referring to India. Um, Frankly, my experience has been otherwise. As the DDG, I was never refused a new idea, and probably you're aware of how many new things I was able to roll out. We were able to roll out the BPALM. We were able to double the NPY support. We were able to expand the Nikshay Mitra food basket to include, food for the family. We rolled out the TB Mukt Bharat Abhiyan, where what Dr. Satyanarayan shared earlier, that we were able to scale up the NAT in such a big way that we were offering NAT, we were, telling the states to use NAT as the baseline test and not microscopy. The microscopy we've reserved for following up TB patients and not for diagnosis, because it gives us two advantages. One, the limit of detection of the NAT test is much better than the microscopy, so we do not miss cases. Two, it gives us resistance to rifampicin, which decides what regimen is to be initiated in the patient. So these NAT tests, at the beginning of last year, were countrywide. 30% NAT was being done, 70% diagnosis was being done using microscopy. We worked so hard to ensure supplies, ensure NAT systems under the program. We were able to scale it up to close to more than 70%. And soon, I guess, we will be able to achieve 100% baseline diagnosis using NAT. Such has been the scale up because we had the indigenous technology. as well available to us. And frankly, the scale up of the NAT systems across the country has also been a phenomenal effort by the program. So, probably you mentioned resource limited setting. We could think of other countries where the resource, in fact, I take pride in sharing with you, India is one such country where all the TB care is being done by domestic budget from the National TB Elimination Program. I bring this up because some of the developing countries are dependent on foreign funding and are actually having a difficult time now because they are unable to procure their basic drugs because of funding cuts globally. Your other part of the question was, could you repeat that, please, Dr. Muskan?
Ma'am, I was just the first part of the question was what innovations in diagnostic could help detect TB better, faster.
So I'll allude to the innovations. So there have been a lot of innovations in the past few years, and I mentioned about screening and the effort of active case finding under the TB Mukt Bharat Abhiyan, where we are not just sitting in our health centers, but we are reaching the common man, through camps, through mobile medical units, offering them X-rays for active case finding. So the innovations that have actually helped us is, handheld X-ray, which may appear as not something phenomenal, but it's a lightweight, portable equipment which can actually, you can carry it. We also have some groups where till mobile medical units are in play, people could carry it in a bag on one's back on a mobike, and it can be taken to a remote area where X-rays can be taken. And these X-rays have been mounted with an AI tool, which is, in fact, several AI tools for X-rays are now available in the country. But what we are using currently is something developed by the IPR, that's Department of Atomic Energy, along with ICMR, and in fact, ICMR has validated that tool. We have been able to mount the AI tool onto these X-rays so that the on the spot diagnosis, in fact, what we only need to do, so the X-ray is just a screening method, it is not a diagnostic method. We do not want the X-ray to tell us if the patient has TB or he has cancer or he has a nodule or he has some other ailment of the chest. We only want to know an abnormal shadow, which is then confirmed using a specific diagnostic modality like a NAT or a culture or a smear, the fastest being NAT, and a point of care test. That is what we do. So these innovations have actually enabled us to scale it up. Our screening, we have been able to scale up, and I probably shared the numbers we've been able to report. Thanks to the TB Mukt Bharat Abhiyan we rolled out, we have been able to report 32.65 lakh patients in the year, just because we've been able to push active screening, reaching the unreached, difficult to reach populations, reaching all vulnerable populations. That is the effort. Possibly if we were not able to do it in TB Mukt Bharat Abhiyan 1, we'll be able to do it now. And like Dr. Satyanarayana said, screen all in-bed patients who are symptomatic, screen at least 10% of OPD population. So basically, we are expanding our net thanks to these innovations. By expanding our net, one, of course, we are increasing awareness of our common man that they would need a screening despite the absence of symptoms. They should get a screening done. That awareness is being spread. In fact, the National TB program is making a lot of effort through their ACSM activities. They're trying to bring in the awareness amongst the common man is very important. And the other innovations I must share with you are the newer NAT systems, which will bring down the cost as well as improve the sensitivity of the NAT. We have the new open RT-PCR systems. We have data on samples like tongue swabs, which is improving as we speak day by day. We are getting point of care NAT systems, which will also tell us resistance in addition to rifampicin. We'll know resistance to INH. Simultaneously, we'll know resistance to quinolones, so we can treat INH monoresistant TB with the right treatment. As of today, knowing rifampicin resistance alone helps us differentiate rifampicin sensitive and rifampicin resistant TB to treat them in the right manner. But if we have additional resistance knowledge at the baseline, we'll be able to offer them the right treatment so that they do not develop, an MDR TB at a later stage. So those kind of innovations are available with us now under validation. PathoDetect is one such system that is validated by ICMR, taken up by the program, which offers both INH and rifampicin. But there are several other systems being validated currently, which will be able to give us these advantages as well. In addition, I would like to also say, expanding our net, I used these words earlier. If we can diagnose TB early by reaching the community, we would probably be able to diagnose, that is what most countries have done. Japan has done it over 4 decades, Vietnam has been doing it and have been able to actually bring down their burden. China has done a phenomenal job by just using these basic tenets and expanding the scale to reach each and every person who needs it. If permitted, we would, in fact, by permitted I mean if we are capable, we could scale up the screening to beyond the vulnerable risk groups, in fact to the whole population, which will enable us to find all the TB prevalent, to break the chains of transmission within the community, and also in the process we diagnose all possible drug resistant TB. I hope that satisfies the query, Dr. Muskan.
Wonderful insights, ma'am. I think you covered it all, starting from screening to diagnostic tools and to innovations in India that are present for TB. Thank you so much, ma'am, for that wonderful answer. Moving onwards in our conversation, I would like to come to Dr. Prashant. We were talking about referral systems, sirs. My question to you is that how can clinicians strengthen referral system and integrate TB screening more effectively into our routine or respiratory care?
Sorry, am I audible?
Yes, sir, you are audible now.
Yeah, so we are talking about two healthcare systems. One is a private healthcare system or a corporate healthcare system, and one is a government healthcare system. And I can tell you that we are routinely diagnosing TB cases in our setup almost on a daily basis. I diagnose 2 to 3 patients sitting in a corporate setup and with a population which is, coming from a relatively affluent background. So the extent of tuberculosis is there. Number two, referral system. Definitely, if we talk about our hospital, we have a very strong, referral system. As far as the screening is concerned, any patient who has a cough, sputum production, fever, weight loss, unexplained malaise, anorexia gets screened for tuberculosis. Number one, any patient who is a high risk patient, be it in any other specialty, a diabetic, a smoker, elderly patients, kidney. We have transplant center also. We have close contacts. We also do contact screening, which lacks in many centers. So even the close contacts, we call them, we screen them, and patients who are not improving on a treatment, all these patients are screened actively for tuberculosis. And definitely, we have a very strong and robust early molecular diagnostic system. So we prescribe the rapid molecular diagnosis test very early in the screening of these patients or maybe in the diagnosis of these patients. Then, apart from this, we don't shy away from using the early imaging, be it ultrasound, CT scan, or any other modality for diagnosing pulmonary or extrapulmonary tuberculosis. We are very quick. Maybe on day one, I will prescribe all the required things because I know sometimes people don't have the time to come again. They have all busy schedules. So we screen them and prescribe them results early. And as far as the Niksha ID is concerned, this is very automatic now in our centers. The moment the person is positive, the Niksha ID is generated and the patient is referred, the patient is automatically picked up by the government setup. Now it is up to the patient to continue the treatment either with our center or with the center where they wish to go. And that always a counseling is done. Not only that, we ask them to get their contact screened. Number two, the problem which I see is that the compliance of the patient in going to centers which give them weekly dose of medicines, right? And once the dose is given, if the patient is having, say, for example, abdominal symptoms, nausea, vomiting, then they again have to go to the center. And unfortunately, we have a lot of burden, we have a lot of lines, queues, and they somehow start missing the tablets. They will say this medicine is causing me nausea, this medicine is causing me this problem. So that is the problem which is there. We are picking up cases, but the compliance, the sticking to the regimen for 6 months is one of the most important factor which is deterring us from treating these patients, and then this is generating a lot of MDR patients. So this also has to be thought about, and especially both at the government and the private centers. Obviously we call them weekly in the initial part, and then maybe monthly or twice monthly. But there is a issue as far as the government centers are concerned, and I'm highlighting it very upfront and very clearly that this is the reason why many patients come to us actually to get their TB treatment done, because of the queues, because of the no attention given to the symptoms of tuberculosis. Then, if I want to summarize, I would say that the referral systems are very robust. We do refer cases very early, inter-department also, and if required, we send them to the MDR centers. We have good centers in our city, Delhi, from which I belong, and any suspected MDR or diagnosed MDR is immediately referred, and with a proper referral to these centers.
Thank you so much, Doc. Thank you so much, Dr. Prashant, for sharing your daily insights that you follow for different, referral systems and integration that is required in routine practice. And I think it could really shift the needle in early diagnosis of tuberculosis, and how public-private partnership are important. And I think by achieving this, we can eliminate TB from India as well. So coming onwards, and moving ahead to the accelerating of TB elimination, my next series is about accelerating into TB elimination. So, my first question is to Dr. Satyanarayana Mysore, that how can critical care data help shape TB policy and early intervention strategies, sir?
So, first thinking is that diagnosis early, counseling complete, and ensuring that there is no default. These are three things. And TB should be thought of as a default diagnosis in any patient unless and until a specific diagnosis comes through. Always think TB in any patient with symptoms like constitutional symptoms plus chronic weight loss, or in extra pulmonary other symptoms. And advances in diagnostic shorter regimens, global commitment. Now that the WHO is also coming with the end TB strategy. The last but not the least point that I want to do is make active case finding with community-based screening linked to rapid diagnostics and treatment completion support. These are crucial pieces of puzzle, and all these things actually work in addressing the issues that you have raised, Dr. Muskan.
Thank you so much, sir, for highlighting those important clinical related points that would be incredibly really helpful and powerful for strategies following TB. Moving ahead, coming to Dr. Anup, sir, what strategies are essential to combat the growing threat of drug-resistant tuberculosis?
Now, to combat the threat of drug-resistant TB, predominantly we bank upon better diagnostics. And when we say better diagnostics, I mean in two ways. As I mentioned, we have significant problem of extrapulmonary TB also. Why am I bringing this up? Because the sensitivity or ability to identify or diagnose accurately extrapulmonary TB is still limited compared to pulmonary TB. We end up using empiric anti-tubercular therapy based on clinical criteria, etc., or based on biopsies for these people, which might be promoting or pushing for drug resistance, because this may either be warranted or we may be using drug resistant drugs already. So better diagnostics of extrapulmonary TB in terms of sensitivity is something we are looking forward to. I'm quite hopeful from the recent publication from the ICMR on their new test which they have tried out, which is a cell-free DNA detection from the blood, which will significantly improve our ability to diagnose extrapulmonary TB. So better diagnostic of extrapulmonary TB is one. Second is significant capacity building to ensure availability of the rapid point of care molecular testing, which includes sensitivity not just for rifampicin, but as Dr. Urvashi was mentioning during her answer in the last session, includes INH, includes quinolones, includes other second line drugs because linezolid, etc. Because these are very very important drugs when we treat MDR TB, quinolone, linezolid, etc. So when we do a resistance testing, right now most of our focus and ability is focused only on rifampicin. So we are hoping that with the newer tests which the government of India, the ICMR and all are bringing up, just like how we do a TrueNat or a gene expert and differentiate between rifampicin sensitive and resistant, we will be able to get the complete important drug sensitivity, not just rifampicin but the whole gamut, so that we use targeted therapy and we diagnose and treat MDR TB right from day one. So these are the two major things which I am hoping will accelerate the both case detection and elimination of drug resistant TB. Ability to diagnose extrapulmonary TB better, and ability to do drug susceptibility testing not just for rifampicin but for the other major drugs also.
Thank you so much, Dr. Anup, for mentioning those 2 points. About the first point that you were mentioning, sir, for better diagnosis. So, my question is regarding that. How can India scale up some TB diagnostic technologies across both urban and rural healthcare systems?
So, as I was mentioning, in terms of capacity building, the what Dr. Urvashi mentioned in terms of 10,000 plus TrueNat systems and molecular test systems, but in the with the vastness of the country and with the prevalence that we have, we need much more. So we need this rapid point of care testing at much more larger capacity than right now which we have, and I am glad that there are a lot of active efforts being done in that direction. The other case finding, what she mentioned, was using the radiology, which is important because that detects patients who are capable of transmitting the disease. So while we harp on extrapulmonary because of its seriousness, higher impact in terms of morbidity, the risk to the community comes mostly from pulmonary TB because of its risk of transmission. And using active case finding like the handheld radiology and AI-driven diagnostics is a big thing where we are taking these diagnostics, both pulmonary TB diagnostics for identifying people with potential of transmission and diagnosing drug resistant tuberculosis, at least rifampicin resistant, both in any setting, or a field setting, because these, as he was mentioning, these all can be carried on to the field setting of any medical camp, any rural area, and we are able to initiate the right treatment.
Thank you so much, Dr. Anu, for that descriptive response. Moving onwards and talking about some actionable steps, Dr. Prashant, we would like to know from you, sir, that what practical steps can clinicians take to ensure early detection and reduce delays in TB diagnosis?
I think most of this we have been discussing so far.
Okay.
And what I feel is the most important part we have already discussed, that we need to screen early. Early screening will lead to early diagnosis. And we should not shy away from using the rapid molecular diagnostic tests, because I know for some people these tests are expensive in our setups, because we are a private health setup. We don't have free testing facility. But yes, it should be utilized with every patient. And if we have a patient who is suspected to have a resistant tuberculosis, then immediately a referral system should be there, where this patient should be sent immediately to the MDR TB center. And that's what we are doing it. There should not be delay in such patients. And we also ensure a strong adherence system. Not only the early diagnosis, the adherence to treatment is also very important, which frequently is quite disruptive in this scenario. And we have to reassure the patient, you have to give time to the patient that like these drugs may be, there may be side effects, and please don't stop the medicines, do consult us. So I have a helpline which is there, and we have a dedicated helpline 24/7, where any patient of tuberculosis or any other patient can call us with the symptoms that I am having this problem, and then we on the try to solve the problem on the phone itself, because sometimes they're not able to come, they may be traveling, they may be at work. So this is what we have ensured. Then we have ensured a very strong, robust referral system, interdepartmental referral system, where any suspect of tuberculosis gets referred to a pulmonary or an internal medicine physician. Because we can, because a surgeon, obviously they are on the OT all the time, and we need to have a person who can examine, take history, all these things have to be done. So they refer to us, and we have that system in place so that early diagnosis is there. Then infection prevention is one such area which is frequently neglected, or even if we do it, we do it half-heartedly. Ist- those with pulmonary tuberculosis, open TB cases should be suggested to have a N95 mask at least for the first 2 weeks of treatment. They should be advised about contact isolation, all these practices, because one patient, can, just like a COVID patient, can transmit the disease to another 10 or 15 patients, individuals, and they can later develop the disease. So this is something which we have to stop, and also contact tracing. We ask these patients and their family members who are close contacts to come and get examined, and we are doing it for free. So that is something. These are few things which I have. I mean, I may be missing something, but I think these are the few things which we are doing in our center to ensure early diagnosis, compliance, and completion of treatment.
Thank you so much, Dr. Prashant, for sharing those clinical level steps that you have taken. And I think that can truly drive the immediate impact upon TB. So, as we are moving onwards to the end of our discussion, I would like to ask two small questions to each of our panelists that, in one sentence, what is the single biggest barrier to end TB today? We would like to know point of view of each panelist, starting with Dr. Satyanarayana, sir.
So, do not think that TB is a disease of the past. Well and truly, it is in a epidemic stage setting. Think TB and utilize lot of advance in diagnostics. Look at shorter regimens, ensure compliance. Counseling plays the most important role. um, Active involve the NTEP, like how we have merged private public mixing. Your nearest NTEP can liaise with the hospital to ensure community based screening, and make use of all this to end the TB. Thank you.
Thank you so much, Dr. Satyanarayan. Dr. Anup, would you like to add something?
So from my perspective, I think still the biggest barrier to TB elimination remains inadequate awareness both among the public or the patients, and also importantly among the healthcare workers. As Dr. Satyanarayana was mentioning, neither is TB a disease of the past nor TB a disease of the poor, because many believe that with affluence you eradicate TB, and rich people or with good nutrition you do not get TB. So tuberculosis has to be considered as a differential in all sorts of clinical syndromes in all socio-economic classes. And the second is also regarding the adherence to guidelines of tuberculosis. Now, adherence to guidelines with the NTEP programs are extremely important if we want to keep a hold on these new drugs, this 6 monthly shorter MDR regimens, etc. We have to use them by the book, and any defaults or the shortcuts in using these drugs inordinately will be again a big barrier to elimination.
Thank you so much, Dr. Anup. Dr. Prashant, would you like to add something to the barrier that we're talking about?
Yeah, I agree with Dr. Satyanarayan and Dr. Anup. And I would like to also include one fact that one of the biggest barriers is delay in diagnosis. Uh, and these undiagnosed patients add to the burden of tuberculosis in the community, because they are the patients who are going to spread tuberculosis. And then this vicious cycle continues, and we need to break this cycle. So, early diagnosis is very important, and I think one of the biggest barriers in tuberculosis management in this country.
Thank you so much to all the panelists for sharing your point of view. My last question to you, all of you, is that any biggest misconception that you have most noticed in your routine clinics about TB among the public? Dr. Satyanarayan.
So the most common this thing we notice is disbelief. I cannot have any, I cannot have TB, but I can have anything else type of a thing. And that fundamental disbelief in the diagnosis can be overcome very easily by NAT testing or gene experts and other something to actually communicate in a crisp, effective way to say that yes, you have TB and that is within reasonable, boundaries. So that is one thing we commonly notice in private sector.
Dr. Anup, would you like to add something?
Yeah, so two common misbeliefs which I see in my day-to-day practice while managing tuberculosis patient is one, they say that no one in my family has it. So many of them still believe that it is hereditary, because nobody in the family had it, I can't have. So that part of it, that is one. Second, they say that I don't have any cough, because I don't have any cough. So again, coming back to that extra pulmonary thing, the knowledge that tuberculosis can affect any organ of the body, and you did not have respiratory symptoms per se to have tuberculosis. So these are the two common misbeliefs that I come across.
Dr. Prashant?
Yeah, I agree with Dr. Satyanarayana and Dr. Anup. I also encounter these kind of misbeliefs. Apart from this, I also have patients who sometimes say, "Oh, the treatment must be 1 year, 2 year," and the medicines are very toxic. They can damage your body, and sometimes some types of TB is fatal. I mean, you cannot prevent this kind of TB. These are also some of the misconceptions they have. But definitely, yes, as Dr. Satyanarayan said, I also emphasize that counseling is something we should do. Spend some time with these patients, explain to them everything. I think then it's easy to treat.
Thank you so much to all of you for sharing those real life examples that you encounter on a daily basis. With that, we would like to conclude today's session, and I would like to thank all of you, our distinguished panelists, for sharing such valuable insights. Thank you so much, sir.
Thank you so much. Bye bye.
Thank you. Thank you, everyone.